What is catheter ablation for atrial fibrillation? So there are three major ways of treating atrial fibrillation for symptoms. The first is just letting the person go in and out of atrial fibrillation, but just slowing it down with rate controlling medications that don't actually get the person from going into atrial fibrillation or get them out of it, just slows it down enough for them to not feel it as much. And that's the least risky way of treating atrial fibrillation. And it's most useful for early stages when they're not in AFib very much, or end stage when you're permanently in AFib, and that's all we can do. But oftentimes isn't good enough when the person's having a lot of symptoms and in AFib quite a lot. Then there is the antiarrhythmic medications, which that makes the AFib cells go to sleep. So they're less likely to wake up, and you spend sometimes years staying in normal rhythm. But remember, that doesn't keep you from ever going back into atrial fibrillation. It doesn't get rid of the AFib cells. It just masks them until it can't mask them any longer, because as you get older, year by year, the AFib cells keep growing, the sources and triggers of AFib keep getting stronger and growing from wall to wall, and eventually they can override the medicine, and then you have to keep just going to stronger and stronger medicines every few years until eventually your AFib is permanent and you failed the strongest medicine, and that's the best we can do. Then we just rate control you. Now, atrial fibrillation ablation is a procedure where we try to get rid of the AFib cells from the inside. So this is a procedure where we bring you to a special procedure room in the hospital called an electrophysiology lab, and we actually access the inside of your heart by poking little holes into your leg veins, not your leg arteries. We are not plumbers. We are not going up your leg arteries or your wrist arteries to your heart plumbing system and shooting dye to look for blockages. That's our interventional cardiologist colleagues, the plumbers. We have no desire to go anywhere near that area. Instead, we just need to get our electrical wires. They look like long pieces of spaghetti. They're very floppy, they don't hurt your heart, and they have metal electrodes at the tip of these catheters, and we have to get them up through your vessels, leg vessels, into your heart so they can touch the walls of your heart. Now, we can use either arteries or veins, but it's actually much safer to use veins than arteries. Remember, an artery is a vessel that carries oxygenated blood that has oxygen that it's giving to the rest of your body. That's the bright blood that spurts out like a pump if you puncture an artery, versus a vein, which is the blood that's given up as oxygen, the deoxygenated blood that's returning back to the heart so it can be pumped to the lungs and get oxygen and become arterial blood. So this is the dark blood that dribbles out when you puncture a vein. It's like the IV line or your blood draws. It's the dark blood dribbles out. And so it's safer to go up the veins. And so we actually puncture several little holes in the leg veins, and we put several electrical wires up under X-ray into your heart, and they touch your heart from the inside. They don't hurt, they're floppy, they don't hurt your heart from the inside. And as they come out of your leg veins, these little wires are attached to an advanced computer system that actually allows us to sense the electricity everywhere these little wires are touching. So depending on how many little wires I put up and how many walls of the heart I touch, I can sometimes see 20 or 30 separate channels of active electricity on giant computer monitors simultaneously in real time, one after the other. So I can actually see the electricity flowing from all over the heart. It's like doing EKGs from the inside of your heart. And so we do that, and then we try to map out where these abnormal sources or AFib sources or triggers are, and then we actually try to get rid of them from the inside directly. This is the so-called ablation catheter. So we put another catheter up, has a metal tip or sometimes a little balloon that we go up under X-ray into your heart, and then on the handle there's knobs, and as I turn the knobs, the tip of the catheter kind of bends, torques, moves around, so we can kind of control it from the outside, and we get it to touch the wall of the heart where we've mapped a cluster of these AFib sources or cells to be, and then we turn the catheter on, and depending on the energy source, the tip of the catheter either gets very hot or very cold. Really depends on the energy source. These days there's a newer energy source coming out called pulse-filled ablation, where it uses electrical pulses to kill off cells without burning or freezing them, but regardless of which energy source you use, you're destroying these cells with the idea that if you can get rid of many or most of these AFib cells, sources, or triggers, that the person won't keep going into AFib if the source of it is gone. And then we pull the little catheters out, hold pressure on the little holes when we're done, and usually give it about 2-3 months to let the cells try to fully die off, because it's not an instantaneous all or nothing thing. And then we assess how much of this did we get rid of. Now, this is trying to do something that the other two modalities of treating AFib don't do. See, the rate controlling medications, they don't actually get rid of the AFib cells, they don't keep them from waking up, they're really just slowing them down, trying to make you not feel them. So they're the least risky thing you can do because they're not really doing very much. The antiarrhythmic medications are more powerful drugs with potentially more powerful side effects, but they're actually trying to keep the AFib cells asleep so that you don't keep going in and out of AFib. But remember, they won't work forever because AFib is always progressing, growing stronger, getting more and more sources, triggers, cells. And so they can always override those medicines. And the medicines don't get rid of the cells, they just mask them until they can't mask them any longer, depending on which drug you're using and how strong it is. The ablation, regardless of which energy source you use, is trying to actually get rid of the cells. So I like to think about the ablation as turning the clock back to an earlier stage. So if you think about the AFib as being like a forest fire, and the more walls you have AFib cells on, the bigger your forest fire is. The bigger the forest fire is, the more it's waking up, and the harder it is to put it to sleep with a drug or to get rid of it with an ablation. It's like turning the clock back to an earlier stage. It's not all or nothing. The ablation is certainly not all or nothing. It really depends on what stage of AFib you're in, how big is your forest fire, how many walls they're on. So the analogy I would use would be, it's like if you were a forest ranger. So let's say you're a forest ranger with 30 years experience, and you're really good. You have a great reputation of being able to put out forest fires that nobody else can put out. And I come to you and I say, okay, I'd like you to put out this forest fire in my hometown. Can you tell me what your success rate's going to be? And you're going to go, wait. You haven't even told me how big the forest fire is. How can I tell you what my success rate's going to be? You haven't even told me how big the forest fire is. And I say, oh, okay, well, it's a 10% forest fire. And you kind of laugh and you go, well, I mean, I'm not going to tell you 100% success, but, close, 90 to 95%, because, who can't put out a 10% forest fire? It's not a very big fire. Even my junior partner here with, 1 year training or experience could probably put it out with an 80-90% success rate, because easy is easy and hard is hard. A small forest fire, it's easy to turn the clock all the way back down to 0 because it's just not that hard, it's just not that big. But if I told you it was a 50% forest fire, you might say, okay, that's definitely more challenging. I think I can still put that out completely. I definitely can make it smaller, but I'm pretty sure I could put it out completely. I'm not going to quote you a 90-95% success rate, but maybe 80-85% success of putting it out completely, not just making it smaller. But it'll take me longer. It'll require more effort. It might require more than one procedure or more than one attempt, but I think I can do it. My junior partner here, who's not that skilled, honestly, in my opinion, probably no matter what he tells you, he or she tells you probably 50% likelihood that they could put it out completely or make it smaller because they're 40-50% because they're just not that good, and it's a harder forest fire. If I told you it was a 90% forest fire, you might say, look, I've done this for 30 years. I cannot guarantee you I can put that out completely. That's going to be really hard. That's so close to being permanently there. But I feel strongly that I have the skills to turn the clock back almost to 0, either to 0 or maybe get rid of 90% of it, make the forest fire a lot smaller. If I make the forest fire a lot smaller, then it's not going to wake up as much because there's a lot less cells, a lot less sources. I can turn the clock back to an earlier stage. I think, 70% I could either get rid of all of it or a good portion of it or most of it. My junior partner here, honestly, 10-20% chance that he can even make it smaller because it's just such a difficult forest fire. So you have to look at it that way. It's not an all or nothing thing. So if you decide to do an ablation, it really does depend, the success rates really depend on what stage are you in. If you wait until your AFib is mostly there and have failed a bunch of antiarrhythmic drugs to keep it asleep and it's verging on permanent, it may not matter who you go to, the success rates may be not that great. Whereas if you small forest fire, you only had AFib for a couple of years, you're only in at 5%, 10%, it really doesn't matter who you go to. They're probably going to have a high success rate because easy is easy and hard is hard. And so therefore, really, when it comes to an ablation, at the earlier stages, it really doesn't matter who you go to. They're all going to shoot for a high success rate, even those who are less skilled. But if you do have a much more involved forest fire, much bigger, it does make more of a difference who you go to, what they do, and that will determine whether they can get rid of all of it or most of it and how many times they can do it. Some people don't do complex ablations and they may not be able to get rid of a bigger forest fire no matter how many times they do the procedure, even though they're getting paid for it multiple times. Somebody else may be able to do it, but they might need 3 or 4 attempts, whereas somebody else might only need 1 attempt or 1 or 2 attempts. So at the later stages, it does make a difference who you go to and what they're doing, but it all revolves around your stage. The more closer you are to this being mostly there or permanent, the harder it is to get rid of this. So people say all the time, oh, I had a friend who had 1 ablation, they got it, and he's had no more AFib. And I had another friend had 3 ablations to get it. Does that mean that friend A's doctor is great and friend B's doctor is terrible? Maybe. I've seen that, but it's also possible that friend A had a 10% forest fire, and no matter who he or she went to, they were going to get a good result, and whoever they went to wasn't even that good. And then friend B had 80-90% forest fire and did go to somebody who did fairly complex ablations, and we're having trouble getting it because it's just a much more involved procedure, a much bigger forest fire. So you have to think about it that way. It is not all or nothing. And even when you do the procedure, it is not instantaneous. It is not, oh, I did it yesterday, starting tomorrow, I'll have nothing, even if they think they got rid of all of it. Because some of these cells, they take a week, a month, even a couple months to fully die off, and some of them may not die off. So it's like a forest fire. If you work really hard to put out a forest fire and you think you got most of it, depending on the size of it, and then afterwards you see a bunch of hot coals or little embers. Now, most of those hot coals will snuff out, but is it possible that a little bit here and a little bit there may survive and cause little residual patch fires? Yes, that's why even when we think we hit all the right areas, doesn't mean that a little bit here, a little bit there might not survive, and maybe you get rid of 98% or 80% instead of 100%. That's always possible. So that's why they have this so-called 3-month blanking period, that after an ablation, whether somebody did a lot or little, they always have to give it 3 months before you say the final results for sure. But it is not all or nothing, and it is never a permanent cure. That's the other thing people always think. Oh, it's a cure, so if you cure it, then I'll never have this problem ever again. Well, why would AFib be cured? We just said the primary cause of atrial fibrillation is getting older. Age is the primary cause. Certain other things like high blood pressure, diabetes, sleep apnea, they can accelerate it, but like a blocked heart artery, as you get older, it could still happen. And so that's why it overrides these antiarrhythmic drugs, because you're getting older, it's getting stronger, you're forming more. That's why it overrides that. So if we get rid of the AFib, even all the way back down to 0, why would that be a permanent cure? Like a blocked heart artery, if you spent 10 years to block up a 10% blockage to 80% blockage, and once you're past 75% blockage, that's where we say it's blocked enough to cause chest pain, heart attacks, damage, and now you're 80% after 10 years and somebody opens it back up to 0 or 10% blocked, do you celebrate and say, yay, I'm cured of heart disease, I will never have that ever again? No, because you know that it can form in other areas or in that same vessel over time. Well, AFib tends to form in a lot of different areas, and so you could ablate a lot of it, you can get rid of a lot of it, regardless of what energy source you use, but it can still form in other areas. So it's not usually a permanent cure, and how much ablation you need will kind of depend on what stage you're at and how easy it is, but it's not all or nothing. And so that's the reason why we don't stop the blood thinner, because we did a successful ablation, because we know that it's not a permanent cure. And if your risk for clots and strokes is high, if the AFib were to ever come back, then if we stop the blood thinner and it comes back, and hopefully if you get rid of enough of it, it's going to come back slowly. It's not going to come back right at 80% if you were at 80%. If you really got it down to almost 0, it'll hopefully come back slower over time through those same stages. If it comes back slowly and you don't feel it right away, and you're not on a blood thinner and you have a clot and a stroke, well then we didn't really help you out very much. So that's why if your risk for clots and strokes is high, if the AFib ever came back and we do a successful ablation, we really shouldn't be stopping the blood thinner, because if it comes back at some point, which there's a high likelihood that at some point it will, even if you don't feel it, you could still have a clot and stroke. So we don't get you off the blood thinner, but it could get you off a bunch of other medicines like rate controlling drugs or medicines to suppress it like the antiarrhythmic drugs, sometimes for long periods of time.